This is Advanced Page Care Theory 2, Unit 11, Part 3, Toxidromes, Part 2. So let's look at narcotic overdose. So opioid or narcotic overdose. Narcotics are opioid receptor agonists. Morphine, for example, interacts with the mu receptors. So there's stimulation of the CNS can lead to analgesia, vomiting, profound sedation in high doses. And the effects can be synergistic with sedative drugs, alcohol, benzodiazepines, and the majority of fatal overdoses usually involve co-ingestion of other substances. So the toxidrome for opiate narcotic or opiate narcotic overdose is depressed LOA, respiratory depression, which is usually what kills people, and pinpoint pupils. And so, as we talked about before, the number one intervention is to manage the airway and breathing. And if that's all that's done, that's usually enough to keep them alive. It's unusual to get narcotic overdoses where we're seeing hypotension and bradycardia, but these can result from respiratory depression. So if you address airway and breathing, then you can avert or correct hypotension and bradycardia. So common narcotics include morphine, hydromorphone, codeine, heroin, Demerol, fentanyl, methadone, oxyneo, oxycodone, oxymorphone, Percocet. And the half-life of most narcotics is between 1 and 5 hours. Duration of naloxone is only 30 to 45 minutes, and you know this already, so we know that one of the risks associated with giving a narcotic or suspected narcotic overdose naloxone and giving it a high enough dose is you wake them up and they could potentially cancel on you, and that puts them at very high risk. With the exceptions, so methadone is about 24 hours, and pulmonary edema occurs in many narcotic overdoses. Interesting, I've had a fair number of narcotic overdoses. I can't say an excessive number. In fact, I haven't given Narcan in the last 10 years, but I've had lots of narcotic overdoses in the past. I haven't had a single one who presented with pulmonary edema. Have any of you had a patient with a narcotic overdose who presented with pulmonary edema? Yeah? Okay, cool. Died in the field. Okay. Yeah, interesting. Really, eh? Now, was this a young patient, older patient, Chris? 25. Wow. That's bizarre. And did you find out about the autopsy results? Were there any co-ingestions? Was there a pre-existing cardiac problem, like a cardiomyopathy or anything you're aware of? Huh, interesting. Okay, well, there you go. So management, supportive largely, and airway control. Intubation, usually we don't go ahead with intubation because we have a potentially reversible cause, right? So usually just airway management with an NPA or an OPA. We manage the airway, we oxygenate, we ventilate, and we give Narcan according to your medical directive, 0.4 to up to 2 milligrams IV, IN, sub-Q. And how you want to give that is up to you. 0.4 IV is not unreasonable. I might give 0.4 nice and slowly, intravenously, like literally over a minute or two. That sounds like a slow push. It is a slow push, but I'll give it that way. And I may not give the full dose if if at 0.2 their respirations are decent, then I'll just cut it off there. 0.8 sub-Q is probably the next safest bet. I'm reluctant to, if I get, honestly, in the past, not so much anymore because I've had this discussion with my medical director and some other people, but the expectation is you're going to give Narcan to suspected opioid overdose. But in the past, my approach would have been, if they're GCS of 3, I'm going to manage their airway, transport them to hospital, and let them do the waking up. But after some discussions, I was told, you're expected to give Narcan. So I said, okay, fine, I'll give it, but I'm going to give it in a very low dose, very conservative dose, because I want to avoid two things. One, if there's a co-ingestion, I don't want to raise them up from a GCS of 3 to a GCS of 9 where they're beating the crap out of me in the back of the ambulance. And two, I don't want to give them a sufficient dose to wake them up completely and have them cancel on me, because that is a real problem. That is a real concern, and you can't take them against their will. If they're awake and they're oriented to person, place, and time, and they decide to decline transport, there's not really much you can do about it. So naloxone is a receptor antagonist. It has a half-life less than 2 hours, but more importantly, it has a duration of only 30 to 45 minutes. So repeated doses may be required because the length of duration of the narcotic is longer. So a failure to respond to Narcan suggests co-ingestion with other drugs if you're giving them a high dose. And the common ones that won't respond to naloxone would be like benzodiazepines and barbiturates that present much like a narcotic overdose. So the management, supportive, airway control, I would say probably minus intubation, but it's a judgment call. Ventilation, Narcan 0.4 to 0.8 sub-Q IM/IN IV. Naloxone is a receptor antagonist. We've already mentioned that, and repeated dose is required sometimes. Although it's unlikely, with short transport times that you and I are going to repeat Narcan. But it just depends on how they respond. So I've already mentioned this. I think it's a repeat slide. Sedative hypnotics. So benzos in particular, we see a lot of overdoses on benzodiazepines, and it binds with the benzodiazepine receptor in the CNS cells, and that promotes interaction between the GABA aminobutyric acid, or GABA, and its receptor on the neurons, and the neurons become more permeable to chloride, which is a negatively charged ion. And when there's an influx of chloride inside the cell becomes more negative or hyperpolarized, and so it takes the cell longer to reach threshold depolarize, and that's how we get CNS sedation. So that suppresses the spread of seizure activity and raises the seizure threshold. It also depresses their level of awareness. Benzos alone are rarely fatal, but may be fatal when they're co-ingested with alcohol or other drugs. And the management, pretty straightforward, supportive, airway, breathing, circulation, SpO2, ECG, O2, PRN, BPV, PRN, IV access, fluid resuscitation, PRN for hypotension. Flumazenil is the antidote, but it's not a pre-hospital drug, and even ER docs are very reluctant to give flumazenil because if the patient has an underlying history of seizures and you happen to give them flumazenil, those patients can go into seizure, and it'll be seizures that are refractory to any treatment. And that's a problem. Cardiovascular drugs, let's talk about those. So types of overdoses we may encounter include beta blocker overdose, calcium channel blocker overdose, and they may present with delirium or coma or seizures. ECG changes include QRS and QT prolongation. And prolongation of the QRS is predictive of seizures. So again, get a 12-lead early and look at the QRS duration from the 12-lead analysis. So it'll tell you it's 80 milliseconds or whatever, 100 milliseconds, and then check it again 15 minutes from that point and see if it's widening. If it widens by 50% or more, that's highly predictive of seizures. So just anticipate that you might see seizures in those patients. Can cause severe hypotension and bradycardia. AV blocks are common, and for long QT, just as a refresher, if the QT is greater than half of the RDR interval, then it's considered prolonged, or look at the 12 lead. If the QTC is greater than 500 milliseconds, that's prolonged. That's a concern, right? So clinical effects with beta blocker overdose, you can also get hypoglycemia due to inhibition of glycogenolysis, and or hyperglycemia due to impaired insulin release may also occur in some cases, worsened by the antidote therapy, which is glucagon, right? And bronchospasm can occur with patients with a history of airway disease. So one of the reasons they don't treat asthmatics who have a history of hypertension with beta blockers is because it may precipitate asthmatic attacks of bronchospasm. So asthmatics you'll typically see on ACE inhibitors for hypertension rather than beta blockers or calcium channel blockers. So management for beta blocker overdose, support the ABCs, SpO2, ECG, O2, PRN, IV access, fluid resuscitation, and if they've got hypertension, bradycardia, we patch the BHP for an order for glucagon. The standard dose for glucagon and beta blocker overdose is 0.05 to 0.15 milligrams per kilogram, or 3 to 10 milligrams for an average adult. Where I work, we only carry 3 milligrams, so you'd have to call in backup crews if you wanted to give more than 3 milligrams, but chances are you get someone with a beta blocker overdose who's in extremis, you're probably going to get a backup crew anyway if you're working in an urban center. If you're working in the remote outskirts of Sudbury, you might be in trouble. Pacing is an option for bradycardia, but pacing may not be effective in beta blocker and calcium channel blocker overdoses, so just be aware of that. Now, just out of curiosity, do you remember how glucagon works? How it increases blood pressure? So glucagon works through a secondary messenger system, so it doesn't work through the beta receptors or the alpha receptors. It works through a secondary messenger system right in the cardiac cells, and that increases the force of contractility. Let's look at some of the over-the-counter medications. So salicylates. Salicylates like aspirin cause nausea, vomiting. That can lead to von depletion, ringing in the ears, hyperpnea. So it stimulates the CNS system, the respiratory system directly. Also stimulates the release of CO2 from skeletal muscle, and that can cause tachypnea and hyperpnea. It causes gastric irritation. Initially, salicylate overdoses will have a respiratory alkalosis, eventually followed by a metabolic acidosis. And so there's stimulation of chemoreceptors. So it stimulates the respiratory system directly. As I mentioned, it causes an increase in CO2 production from skeletal muscle activity. And so initially there's a hyperventilation with a respiratory alkalosis, and that to counter the metabolic acidosis. And then initial respiratory alkalosis causes the kidneys to excrete bicarb and potassium, which later impairs the body's ability to handle a metabolic acidosis. So the management, ABCs, SpO2, ECG, O2, PRN, don't coach breathing if they're hyperventilating or tachypneic or hyperpneic. PPV, PRN, IV access TKO, patch to BHP for an order for sodium bicarbonate, 1 to 2 milliequivalents per kilogram. I had a patient once, I may have told you the story. She was a 91-year-old patient who ingested oil of wintergreen, which is a Chinese remedy that you rub on your joints for arthritis, and it's almost pure salicylate, and 2 teaspoons of, or 2 tablespoons rather, of oil of wintergreen can be fatal. That's how toxic it is. And we'd given her 4 amps of bicarb and had her on a bicarbonate drip. That's how acidotic this lady was. Acetaminophen, this is one of my favorite toxidromes, Tylenol. And I guess because the signs and symptoms are classically delayed, and you know, people think it's not that serious, including the patient, and they may have some non-specific GI signs and symptoms, sometimes within 24 hours, oftentimes starting around 6 hours to 8 hours. And so acetaminophen causes hepatotoxicity and necrosis as early as 12 hours of the onset. So, you know, these patients, they take an overdose, and all they need to take in is about 14 grams, which is 28 extra strength Tylenol. And they feel fine, and maybe then they start to get some stomach upset and they call for help, or someone else calls for help. One of the later signs is a right upper quadrant pain. That's when the liver starts to get damaged. And most fatalities occur about 5 days post-ingestion. And so a toxic dose is 7.5 grams in adults, 150 milligrams per kilogram in a child. And a fatal dose in adult is about 14 grams, unless they've got cirrhosis of the liver, liver failure to begin with, and a lower dose may be fatal. Oops. So management, largely supportive, SpO2, ECT, O2, PRN, PPV, PRN, IV access. Hospital management, they give them activated charcoal to try to absorb some of that, and they give them mucomist or N-acetylcysteine if they've taken, if they've ingested it in under 8 to 10 hours. So beyond that, it may not be effective, but they may use it anyway. You know, 14-hour mark, 15-hour mark. So, in summary, in terms of toxidromes, you know, basic understanding of the nervous system and the general physiology is important, and we always have to consider that an overdose is going to involve more than one substance, and so the classic toxidromes don't always apply. You know, the narcotic overdose may not always have pinpoint pupils, and if you document the pupils are pinpoint, you can't document the reactivity, because if they're pinpoint, you really can't see them react. You know, if they're a couple of millimeters, you might see them react. I don't consider that pinpoint, but if they're truly pinpoint, you really can't document the reactivity. So there are some specific antidotes, but they don't replace the need for basic supportive care, air, breathing, circulation. So we want to gather evidence. That's probably one of the most important things we do, because once we leave the scene, the hospital can't go back and gather that evidence. So what did they take, how much, when? In triage, oftentimes they do a pill count. I made the mistake of trying to do a pill count in the back of the ambulance once and lost a whole bunch of pills under the bench seat and had to go searching for them later. It was just one of the dumbest things I've ever done. What, how much, when, always keep a high index of suspicion, err on the side of caution over triaging these patients. Overdoses basically all get a C-test too, and you know, if there's an antidote, we want to apply that. These are some examples of antidotes, things that we carry, things we don't carry. So the antidote for narcotics, as we know, is Narcan. For acetaminophen is N-acetylcysteine. For iron is deferoxamine. Ethylene glycol or methanol is either IV alcohol or fomepizole. Fomepizole is, I don't know what the cost is now, but it used to be about $2 grand. I think it's still fairly high. And it's interesting because I remember attending a conference on toxicology, and there was a toxicologist from New York City who came, and he was saying that his fomepizole cost him about $2 grand, but a good friend of his was a veterinarian and got the same drug, concentration and everything, for $150. So he would get his fomepizole to stock his ER from his veterinary friend. For cyanide, there's hydroxycobalamin, and some supervisors carry hydroxycobalamin. Now, curious, do you guys have do your supervisors carry hydroxycobalamin for smoke inhalation patients? Just your CBRNE team? Yeah. Cyanide's a common product of combustion, and so there's some agencies that recommend the antidote for fire calls. For organophosphates, we'll talk about that next week. Atropine, pralidoxime rather, 2-PAM. For digitalis, Digibind. Now I don't know how many hospitals carry Digibind. I know Sick Children's Hospital carries it, and maybe some of the downtown Toronto hospitals, but definitely not all hospitals. And we don't see digitalis or digoxin very often anymore. I had I think it was a 3-year-old who ingested her grandmother's digoxin, and she was bradycardic and hypotensive, and we had to take her to Sick Kids to get Digibind. For anticholinergics, it's physostigmine, and for benzos, it's flumazenil. That's it for part 2. Any questions about this section? Sorry, Chris, what was the doctor recommending for GHB? Recommending digoxin for GHB, not Digibind, digoxin. That's interesting. Anyway, strange.